Hello, my name is Demetre Daskalakis, and I'm the Director of the Division of HIV/AIDS Prevention at the Center for Disease Control and Prevention. And today, I'm going to talk about the status-neutral approach, which is really a whole-person approach to ending the HIV epidemic in the U.S. So today, I'm going to talk about why a status-neutral approach is needed, what is a status-neutral approach, and how is CDC advancing status-neutral HIV care, as well as recommending some ideas for the way forward for our various important stakeholders, whether they be public health or clinical care. So I'll start by really talking a bit about the background. Why is a status-neutral approach needed? And the answer is really simple. HIV stigma is a prime barrier to our work to end the HIV epidemic. We know HIV stigma is rooted in a fear of HIV and supported by systems that otherize people with HIV. So when I say otherize, it means when people with HIV are made to feel different or are treated differently than people without HIV. And we know from racism and other isms that they are systematized, that they exist in institutions and propagate that exact stigma and potentially have bad impact on people's lives and their health outcomes. So let's go deeper. What is HIV stigma? So HIV stigma is defined by the negative attitudes and beliefs about people with HIV. It is also prejudice. It comes with labeling an individual as part of a group that's believed to be socially unacceptable. Examples of HIV stigma can be that believing only certain people can get HIV, making moral judgments about people who take steps to prevent HIV transmission, and feeling that people deserve to get HIV because of their choices. It's also important to remember that stigma manifests in different ways. It can be internalized, anticipated, experienced in healthcare settings, all of which I'll talk about briefly. So first, let's talk about internalized stigma. Internalized stigma happens when a person takes in the negative ideas and stereotypes about people living with HIV and then applies them to themselves. HIV internalized stigma can lead to feelings of shame, fear of disclosure, isolation, and despair. These feelings can keep people from getting tested and treated for HIV, and from people living with HIV potentially interfere with their connection to medical care, antiretroviral medicines, and ultimately improvement of their health as well as prevention of transmission. Anticipated stigma is the belief that prejudice, discrimination, and stereotyping will be directed at the self from others in the future. For those of us who care with people with HIV, we know that this happens in every aspect of life, whether it's applying for a job, looking for a new romantic or sexual partner, making friends, etc., and ultimately coming to care. So researchers have examined how internalized and anticipated stigma affect HIV-related outcomes. Internalized and anticipated stigma have more influence on medication adherence than experiences of external stigma or discrimination. Let me say that again. Internalized and anticipated stigma have more impact than experiences of external stigma or discrimination. Internalized HIV stigma leads to people not being virally suppressed due to what is, in effect, a domino effect of a person displaying depressive symptoms, which could then impact their medication adherence. Again, a whole person issue. When people experience stigma in healthcare settings, it's associated with not reaching and sustaining viral suppression, poor mental health outcomes, and interpersonal outcomes. Perceived stigma in healthcare settings contributes to internalizing HIV stigma. The institution propagates the stigma. The institution maintains the structures that create a duality that otherizes the person living with HIV. It doesn't just stop at HIV. There is also stigma for individuals who are seeking prevention to prevent HIV acquisition. So PrEP stigma is real. It is defined as stigma associated with using PrEP, and it can be internalized, anticipated, or experienced. PrEP stigma is often experienced at the community level and can be reinforced and even amplified by public health programs, policy, and research. PrEP stigma influences behavior of patients and providers, which then results in people who could benefit from PrEP not being prescribed PrEP and or not filling the prescription and or not taking it. So both potential and current PrEP users have conveyed concerns that others will think that they are HIV positive if they are seen taking PrEP. The idea also that PrEP use could cause a person to engage in higher risk-taking behaviors is also a barrier to access for people who could potentially benefit the most. So not only is there a concern of being stigmatized by entering the HIV space, but also the notion that if you are a PrEP user, you must be very, very high risk. Again, a topic that we can discuss on another day. Behavior is a high risk, people are not. So the effects of stigma are harmful, and those of us who work every day in clinics and every day seeing patients witness it every day. In fact, when I was doing my HIV testing program in commercial sex venues in New York, it was almost the exception, not the rule, that I would meet someone where stigma did not play in to their HIV diagnosis and their connection to care. No matter how it manifests, it has harmful effects. It causes social isolation. It can lead to depression, poor physical health, and poor mental health. And it's a cycle that can continue and is propagated by systems and other subtleties of our strategies that really impact the success of those strategies. As part of our Ending the HIV Epidemic initiative planning, which I will talk about a bit later, CDC asked Ending the HIV Epidemic jurisdictions what were the biggest systemic challenges and structural barriers to actually implementing EHE. Please note the bottom tier, stigma, 30 out of those jurisdictions, more than 75%, indicated that it was the most cited challenge in achieving our Ending the HIV Epidemic goals. Our structures and systems cannot maintain stigma, but must disrupt it. Now, there's another reason that it's important to think about interrupting HIV stigma, which is that it never stands alone. It stands with racism, transphobia, homophobia, and often sexism. Let's talk about some of the ways that the stigma may be institutionalized and its impact on other identities. So first, I'll start with HIV criminalization laws. Most criminalization laws do not reflect current scientific and medical evidence. Many of these laws were passed at a time when very little was known about HIV, including how HIV was transmitted and should be treated. These laws have not increased disclosure and, in fact, may discourage HIV testing, increase stigma against people with HIV, and further exacerbate disparities. Unequal application of HIV criminalization laws has further implications for Black communities, contributing to inequitable incarceration. Black men who have sex with men living in states with versus without HIV criminalization laws were more likely to think their community discriminates against people with HIV and is intolerant of men who have sex with men. Really important. The institution then trickles into people's psyche, into their ability to understand where they fit in society, and generates and maintains stigma. Under existing laws in many states, the behavior of people with HIV can be criminalized for potentially exposing others to HIV. Actual transmission or intent to transmit is usually not required. 37 states criminalize the behavior of people with HIV through HIV or STI-specific laws. 18 states criminalize behavior that has a negligible or low risk of transmitting HIV, such as spitting, biting, and oral sex. 21 states require people with HIV who are aware of their status to disclose their status to sex partners. 13 states have maximum sentence lengths of more than 10 years, in some states up to life, even though people with HIV might have taken measures to prevent transmission. 12 states require people with HIV who are aware of their status to disclose their status to needle-sharing partners. 9 states provide defenses for taking measures to prevent the transmission of HIV, such as condom use, and thankfully now, viral suppression and PrEP. But it's, again, important to remember that's an example of a institutionalized piece of HIV stigma, but it does not stand alone. The intersection of HIV stigma, racism, homophobia, and transphobia is real. An individual's experience with HIV prevention and care cannot be understood without considering different facets of their identity, including their race, gender, HIV status, class, and sexual orientation. Research shows stigma measures are worse for people of color. HIV stigma interacts with other identities. Experienced transphobia was associated with a lower likelihood of transgender women receiving HIV care. Again, other phobias and isms interact with HIV stigma. They are one and the same. The intersection is a real one that we experience daily in our work in clinical and medicine and public health. Stigma and structural barriers are major obstacles that deter people from seeking HIV prevention and care. Homophobia and internalized homophobia are independently and negatively associated with access to HIV prevention among young men who have sex with men, controlling for HIV status, relationship status, education, and housing. Greater internalized homophobia was associated with never having been tested for HIV among Black men who have sex with men. Stigma, in its many forms, was the most cited barrier to PrEP adherence for young men who have sex with men and transgender women of color. We have a lot of issues facing us, and we have a lot of issues making our work difficult. But clearly, stigma remains number one on that hit list. So let's talk a little bit about HIV prevention and care delivery. So really, Ryan White funded facilities are an amazing place. They use a medical home model offering comprehensive patient-centered care for people with HIV. The medical home model is a multidisciplinary approach where care, case management, and support services are integrated and patient-provider relationships are emphasized. The Ryan White program approximates the opportunity for universal health care for people with HIV. I remember when I was in New York City, I was asked, how was New York able to achieve its 90-90-90 goals? And my answer really was that with current levels of insurance and the Ryan White program combined, we had approximated universal health care, a very informative lesson for other medical conditions. More than half the people with with diagnosed HIV in the United States, in fact, receive services through the Ryan White HIV/AIDS program each year. Approximately 75% of Ryan White funded facilities provide on-site case management for wraparound services, like assistance for food, housing, and transportation. Ryan White patients were more likely to have access to on-site mental health and substance abuse services. Because Ryan White only serves people with HIV, people at risk for HIV may not have access to some life-saving wraparound mental health services. Here's an example. CDC's national HIV behavioral surveillance data among transgender women showed that reported suicidal ideation and behavior was higher among HIV-negative participants than HIV-positive participants. Among HIV-negative participants, 22% seriously thought about suicide, 9% made plans for suicide, and 6% actually attempted. Among HIV-positive participants, the numbers were 12%, 4%, and 3% respectively. Really raising to me a flag. Are we missing the boat on prevention from the perspective that it is a whole person intervention that requires interventions that deal with drug use, mental health, etc.? Are we missing the boat for people who are HIV negative and at risk by not offering them syndemic care and syndemic services in a way that's agnostic to their HIV status? So I mentioned the effect of experience stigma and discrimination in healthcare settings can have on treatment outcomes. Experienced discrimination in healthcare settings was higher among those living in poverty, but only among those attending non-Ryan White facilities. So really important to see what happens when there's a wraparound service, when there is a strategy to really welcome people into a place that focuses on them and all of them. So I'm going to give you my story, a tale of two waiting rooms. When I was a fellow, I remember my waiting room for my HIV clinic was actually the same waiting room for the travel clinic and the state STD clinic that were co-localized on the same floor. It was actually a remarkable thing to see to walk into the room and see all sorts of humans, whether they were HIV negative or positive, sharing the same magazines, breathing the same air, having the same conversations, and generally very peaceful interactions. Fast forward to going to my first position as an attending physician. And one of the places that I worked had a HIV clinic called Virology. There was a big sign that said Virology on top of it, and it was located very close to the geriatrics clinic. So it was inevitable that almost every day we would have to call security because there were always clashes and fights in that area. There was an us versus them. There was a positive and negative. There wasn't a feeling that we were all here getting care, but instead, this story is for you and this story is for me, and there's something different about us. Siloed HIV-related services may inadvertently contribute to stigma and hamper care-seeking behaviors. Not everyone is going to want to walk into a venue with a flashing neon sign that says HIV clinic, nor one that says this is where you get PrEP. Instead, we must think about breaking this cycle and embrace a comprehensive whole person approach to care that places the person ahead of their HIV status, really focusing on comprehensive care. Health to me means restoring wholeness and unity. Full disclosure, along with being a doctor, I was a religion major in college, and the words for health, salve and salus in Latin and Greek, actually are the root for salvation, creating wholeness, removing duality. Getting rid of us versus them is a key strategy to addressing stigma. As long as we have a duality, stigma will exist. And as long as our systems maintain that duality, they will also maintain the stigma that defeats the work that they're doing. So that leads me to, what is a status neutral approach? A status neutral approach means that we meet people where they are by offering a whole person approach to care, by putting the needs of the person ahead of their HIV status. This means really not caring whether they're living with HIV or potentially at risk, but rather providing the services that they need to maintain them in care. Removing the duality that is inherent in the system and ultimately addressing stigma where we can on the institutional level. This is a graphic that represents the status neutral framework. It is actually currently a part of the current national strategic plan for HIV and is available both in there as well as in a publication that we are happy to send you the reference to. So let me just talk a little bit about that framework. So it's called status neutral because the same approach is used to engage and retain people in care regardless of HIV status. So the status neutral approach starts with testing. Somebody gets tested for HIV. If their test is positive, they go into a treatment engagement path. If they're negative, they go into a prevention engagement path. A status neutral approach is unique because both pathways promote continual assessment of each person's needs and ongoing engagement in HIV prevention and care, including access to support services for anyone who could benefit from them. This is really a statement about quality of care. This continuous high quality care is the engine that really provides people the tools that they need to stay healthy and help stop HIV, either by maintaining an undetectable viral load, by engaging in care, getting onto treatment and staying on treatment, or assessing and reassessing their need for PrEP and using that intervention when their lives dictate that they need it, while potentially also staying involved in prevention from the perspective of STI screening and other harm reduction strategies that are key, even if someone is not taking pre-exposure prophylaxis. So at the end of the day, HIV testing is the gateway. Quality is the engine that drives cycles of engagement, and engagement results in good health outcomes, regardless of the HIV test result. I remember when PrEP came about, I realized that I was getting my PrEP patients and people living with HIV confused. I didn't remember if I was ordering just an HIV test or an HIV viral load and a CD4 count because my care was identical with them. And sometimes I forgot whether they were on HIV medicines for PrEP or if they were on HIV medicines for treatment, which I think is really informative and important in terms of our strategy for caring for people in the same identical way rather than different. Remember, people living with HIV come from the same groups of individuals who benefit from prevention. So it doesn't make sense to silo their care and create different strategies. There's a lot of benefits to a status neutral HIV strategy. That approach to care means that regardless of HIV status, people have access and support to stay on highly effective public health interventions that include PrEP and HIV treatment. When people are supported to fully utilize these interventions, the outcome is the same. HIV infections are prevented, whether it's by viral suppression or engagement in prevention services that could include PrEP. By offering HIV services alongside other local healthcare and social support services used by the community, HIV prevention and treatment become a part of the fabric of a holistic care strategy designed to meet the needs of every individual. As a person's needs evolve, they can be seamlessly connected to new services. Let me give you an example. What if someone is HIV negative and seroconverts while they're engaged in prevention? It does happen. Ultimately, the seamless transition of that person to HIV care is very quick and is way more facilitated than if it were in a different setting. The outcome is not only improved HIV care, but better overall health and social stability for every individual. These parallel services and structures that have been historically created for people with HIV or those who can benefit from prevention can impede the most efficient use of our resources and may hinder connection to care by maintaining the stigmatized structures in healthcare, that anticipation that someone is going to judge you. Identifying opportunities to resolve these divisions allow for more streamlined and integrated care. Removing the duality removes the stigma. In addition to integrating HIV and prevention services to better address social determinants of health, regardless of HIV status, this framework encourages the delivery of culturally affirming care by ensuring providers recognize and address their implicit bias on issues like race, ethnicity, sexual orientation, or gender identity. The intersectionality is a key part of this strategy. We know that these biases can prevent people from coming to care and returning. Likewise, countering stigma is essential to ensure that people with HIV are not defined by their status. And that people seeking HIV prevention services can do so and be empowered to access these tools without facing judgment or being reduced to just the result of a lab test. Addressing racial bias and stigma result in better care experience for patients and increase the likelihood that they both remain in care and stay healthy. So how are we advancing status neutral HIV care? So there's a lot more to come on this chapter, but I'll start by talking about the ending the HIV epidemic in the US. This is a multi-agency federal initiative that aims to reduce new infections in the US by 90% by the year 2030. Through ending the HIV epidemic, CDC is working with partners to accelerate progress by delivering key prevention strategies in ways that are innovative and focused on populations who are hardest hit by HIV. That means diagnose all people with HIV as early as possible, treat them rapidly and effectively to achieve and maintain viral suppression, prevent new transmission by PrEP and syringe service programs, and respond quickly to HIV outbreaks, really the edge of the HIV epidemic, where treatment and prevention fail. Identifying these means that we can add resources and interventions at that edge of the epidemic to further curtail transmission. So our efforts will continue to focus on its 4 strategies. So the ending the HIV epidemic strategies are identical to our strategic goals at the Division of HIV/AIDS Prevention. We have to diagnose, treat, prevent, and respond. That's the formula. And the silent 5th one is we have to address equity issues, which actually permeates all 4. When augmented by EHE funding and our efforts of our HHS and other federal, local, and community partners, these strategies, even though we don't have a vaccine yet or a cure, can end the HIV epidemic in the United States. So a couple of things that we're doing, I think it's notable to focus on our CDC self-testing efforts. We've started this work centrally with a project to distribute 100,000 self-test kits online. But our goal is to make this more part of the fabric by partnering with trusted community-based organizations so they too can extend their capabilities and become testing sites, even if they don't have a lab or other capabilities of doing on-site testing. So how are we going to advance status neutral care? CDC is providing funding and conducting implementation science to improve programs and partnering with organizations across the US to support integrated status neutral approaches to HIV care. We are encouraging grantees to deliver integrated services. Several of CDC's major funding programs provide flexible resources for health department and community-based organization partners to deliver integrated HIV prevention services. That includes a $109 million award to 57 prioritized jurisdictions to scale up the local work and really partner with STD clinics, viral hepatitis programs, LGBTQ health centers, criminal justice and correctional facilities to be able to really provide more streamlined access to HIV services, testing, prevention, and treatment. Additionally, we are providing support for our sexually transmitted disease clinics to really generate status-neutral care strategies that include initiation of antiretroviral therapy as well as PrEP. Beginning in 2021, we'll fund approximately 90 CBOs to develop high-impact HIV prevention programs and partnerships. These CBOs are required to create HIV programs with great potential to address social and structural determinants of health and can use their funding to help clients navigate essential support services. The program will also support integrated screening for STIs, viral hepatitis, and TB, syndemic infections, and referrals for subsequent treatment. Additionally, health departments that receive funding through CDC's flagship prevention and surveillance program are encouraged to use these resources to support programs that adopt status-neutral approaches to HIV prevention and treatment. But it's not just about launching, it's about conducting implementation science. We are conducting a pilot program to evaluate the provision of status-neutral HIV services for transgender people, literally putting transgender services in comprehensive programs that focus on the lives of transgender individuals. The pilot will support transgender healthcare providers and CBOs to integrate HIV, STI, viral hepatitis, and harm reduction services alongside transgender-specific healthcare. The pilot aims to establish best practices for creating a one-door approach, negative or positive, for testing and other interventions that can improve the health of transgender people. And we're building partnerships. CDC is working with other federal agencies and organizations because this is an all-of-government response that focus on the issues that intersect with HIV and affect health outcomes like sexual health, mental health, housing, incarceration, employment, and substance use disorder to advance status-neutral approaches to HIV prevention and care. For example, the HIV National Strategic Plan incorporates the status-neutral framework, like I said, creating opportunities to improve systems. They support the provision of status-neutral services in a national HIV response. These partnerships will enable the sharing of knowledge and best practices that translate to better implementation science, programs, and services. These partnerships can also support better integration of programmatic efforts on the ground. And it's important to remember that CDC's 2021 priorities in the division of HIV/AIDS fit well within the status-neutral approach. In fact, everything is equal, whether we're ensuring health equity, expanding self-testing, or strengthening syndemic collaborations. At the end of the day, this all leads to strategies that support status-neutral delivery. It is critical that we weave health equity approaches into the entire HIV prevention portfolio, as well as test additional concepts, which are designed to increase access to prevention services. And that includes self-testing through innovative delivery models. And then at the end of the day, whole person strategies that are status neutral need to address syndemics. It is not just all about HIV treatment or prevention. It's about STI, it's about viral hepatitis, it's about mental health, it's about housing. It's about all of the important components that are critical in supporting a healthy life beyond even the sort of biomedical strategies of medications and tests. So ultimately, again, really trying to create a one door rather than a multi-door to disrupt the duality that maintains the stigma. Now, we've made a lot of progress. National HIV prevention and care efforts have reduced HIV infections from a peak of 130,000 in the mid-1980s to approximately 34,800 in 2019. But I'll tell you that progress is uneven between different groups, whether it is their race, gender identity, or their sexual orientation. So more work needs to be done to actually drive this HIV epidemic further and achieve the ending the HIV epidemic goals. So a lot of the work that we're doing is at its core health equity work. So we are working diligently in HIV criminalization, really working to make sure that we give resources necessary to look at strategies to address these laws that are often not aligned to science and revise the application for these laws so that people living with HIV are not stigmatized by them or further distanced from care. We are also have an HIV prevention in communities of color postdoctoral fellowship program that recruits mentors and trains investigators to conduct domestic HIV and AIDS prevention research in community of color. And we fund comprehensive high impact HIV prevention programs for health departments and community-based organizations. That's about $400 million a year to health departments and $42 million to CBOs to really focus on prevention. And one of my favorite equity interventions is our comprehensive impact HIV prevention projects for young men of color who have sex with men and young transgender persons of color. And this is an award of $54 million over 5 years to really empower 30 CBOs serving young MSM of color and trans persons of color to really push the science and the program forward in these populations and again, really address areas where folks are overrepresented in the epidemic. At the end of the day, like I said, you can't have a status neutral approach without having a syndemic perspective. So unless you deal with the other issues that face humans other than HIV, you're not going to achieve the goal of creating a status neutral space. So that means you have to think about mental health, substance use, STIs, viral hepatitis, harm reduction. And that to me is whole person care. And that care is status neutral since so much of it is identical regardless of the result of an HIV test. So what's the way forward? So for federal agencies can provide training, support, and technical assistance to state and local health departments, healthcare providers, and CBOs looking to implement status neutral HIV care. They can prioritize strategies that support frontline providers to more easily create status neutral programs. We have to ask ourselves, what are our institutional barriers that don't let me do this? Why can't I do it, and how can I change it? And so that is uniquely in the federal column. Promote cross-agency collaboration to integrate HIV treatment and prevention services with other primary care, behavioral health, and social services. Our pilot in transgender health is a great example. There are services that exist, primary care services that attract people because they address the whole person. So we should build within those HIV treatment and prevention rather than create a shadow environment, a separate environment that misses the boat and potentially misses the population. Saying that a population is hard to reach is actually strange since they access care and services every day. They may not just be going where we think they're going. From the state and local health department perspective, state and local health departments can review their current funding and delivery models to further integrate HIV into STI and primary care settings. So that means really thinking about ways that we can hanker down and look and see how we can integrate in community health centers, sexual health clinics, and drug user health access points. Additionally, the state and local health departments can work with their CBOs and other providers to gather and share best practices and lessons learned in implementing status neutral HIV care. And I think there are some great examples, I think in Chicago and DC, of the work that's happening to really promote status neutral services. And I'm excited to say when we look at our jurisdictional ending the HIV epidemic plans and look at how they match to our CDC priorities, 15 of them included status neutral approaches to HIV in their strategies. So that included conducting a status neutral needs assessment to see how they could more contextualize the strategy to their jurisdiction, creating marketing campaigns with status neutral messaging, and educating providers and patients on status neutral approaches. So I'm going to challenge myself and say we're going to raise that 15 by a lot as we generate more and more information and more opportunities for how status neutral programming can be implemented in jurisdictions. And then the way forward for healthcare providers and community-based organizations. So I actually come from a past of being a medical director from the clinic where I was challenged to try to figure out ways that I could create status neutral services. So very specifically, how I was able to work to make a clinic that was only seeing people living with HIV into one that could see people living with HIV as well as those who could benefit from prevention services, whether that be harm reduction or PrEP. So healthcare providers and CBOs can offer dynamic supportive care that integrates status neutral care through culturally affirming messages that prioritizes each patient's individual needs. We have to disrupt that system to be able to see that change. Also consider providing non-HIV services. that can improve patients' overall health, such as an STI and viral hepatitis screening, mental health care, and substance use counseling, as well as linkage to social services. So really asking yourself, how can I provide a whole person service? And how am I able to strategize the best way to support this service? Participate in regular trainings, of course, on recognizing and addressing implicit bias is key, because again, HIV stigma and bias does not live in isolation. There's just a tsunami of evidence around how HIV stigma interacts with sexism, racism, and transphobia to really defeat our goal of better controlling the HIV epidemic. So in summary, stigma and other systemic factors can influence how people access HIV prevention and treatment services. I want you to remember that pyramid that you saw, where we asked our jurisdictions what were the barriers, and that almost all of them said stigma. So clearly, this is a common denominator. A status neutral approach meets people where they are, and that really means offering whole person care and putting the needs of the person ahead of their HIV status. So no longer, how do I treat this person living with HIV versus this person who's at risk, but how can I treat this person? And how can I create systems and maintain systems that don't continually make the duality? I remind you again, duality means stigma. This approach helps improve care and, like I said, eliminates stigma. We all have a role. Federal agencies, state and local health departments, healthcare providers, and CBOs can actually take steps now to begin promoting and integrating the status neutral approach into their programs and delivery service models. As we make opportunities more available and new strategies and technical assistance, it is really important that we have to acknowledge that addressing this and disrupting this is our role at core to address the issues of HIV stigma that, again, continue to interfere with our progress in ending the HIV epidemic. Thank you very much.